Hello, everyone. My name is Njideka Okubadejo. I'm a neurologist from the College of Medicine, University of Lagos in Nigeria. And I would like to congratulate the MSA United Partners, my friend Philip Fortier, and all the wonderful people affiliated with Defeat MSA for successfully hosting the 4th annual free all-community virtual MSA conference. This is probably the first time we have active participation with a speaker from sub-Saharan Africa, and it's an honor and a privilege to join this global community to shed light on MSA, the challenges, the opportunities, and the unmet needs from the African perspective. So thank you for having me. I bring you greetings from the University of Lagos and the vibrant and multicultural city of Lagos, Nigeria. Recognizing that this conference brings together a really diverse audience and community that includes people with MSA, their carers and families, but also includes researchers and healthcare professionals, I've tried to include some content that may be of interest to the wide audience, with aspects that highlight challenges within Africa and probably of relevance to any underserved population. So overall, my talk seeks to create awareness that MSA does occur in Africa and generally acknowledge the lack of awareness, underdiagnosis and misdiagnosis, and limited access that people with MSA have to healthcare professionals with some expertise in managing MSA. This talk provides an opportunity to shine light on this typically neglected and under-recognized condition, and also advocate for including strategies to address MSA in the broader conversation regarding access to services for people with neurological disorders. In my talk, my main focus will be to provide an introduction to MSA, describe the profile of MSA in Africa, highlight gaps and unmet needs. I'm sure there will be much more than I will highlight in this talk, and also talk about some opportunities that we can harness to improve the diagnosis and care of and support that people with MSA in Africa receive. MSA is the abbreviation that we use for multiple system atrophy, and it's an adult onset neurodegenerative disorder. So what is a neurodegenerative disorder? These are brain disorders that are characterized by a gradual and progressive loss of structure or function of neurons, including death of such neurons. And with MSA, there's a predilection for specific areas of the brain that have to do with the proper control of movement, of balance, but also very importantly of autonomic or automatic control of body functions. So people with MSA have a varying combination of such autonomic failure, Parkinsonism, which refers to slowness and tremor and problems with gait and balance, but also ataxia, which is the consequence of involvement of the brain area called the cerebellum that controls balance. The cause of MSA is unclear. It typically occurs out of the blue, so that's why I refer to it as being sporadic. It is progressive, and for now, no cure exists, even though there are treatments that are available that can improve and help with many of the complaints that people with MSA experience. This cartoon of the brain provides a simplified illustration of the multiple brain areas most affected in MSA. The deep part of the brain called the basal ganglia is affected, and that results in slowness and features resembling Parkinson's disease. The brainstem area, which is the area that controls automatic functions, also known as the central autonomic nervous system, can be affected, and so results in problems with blood pressure control, bladder control, control of breathing, and control of body temperature and sweating. And then involvement of the cerebellum, which is the area at the back of the brain, results in problems such as incoordination of the limbs and problems with gait and balance. Next, I will provide some facts about what we know about MSA and describe the global burden of multiple system atrophy. So MSA affects about 2 to 5 per 100,000 of any given population. It does seem that distribution is similar across most populations of the world. However, because it's an adult onset disease that typically starts above the age of 40, in those aged over 40, MSA can affect up to 8 per 100,000 of the population. In terms of the number of new cases that occur every year, MSA occurs in about 0.6 to 0.7 per 100,000 person years. It's an adult onset disease, and the age at onset is usually between the late 50s and early 60s. There doesn't seem to be a significant sex difference in most of the descriptions of MSA, and the mean survival is usually less than 10 years. On average, it's about 8 years after the diagnosis has been made. And it's typically sporadic, and a positive family history is very rarely encountered, but this does happen. There have been some genetic associations, but this is really an area that is still poorly understood. That is, the genetic contributions to multiple system atrophy are not very well understood. Now, these two relatively recent reviews provide additional information on MSA for anyone who wants to dig a bit deeper into some current concepts regarding the epidemiology, the diagnosis, and the genetic basis of MSA. The article by Werner Poe and colleagues provides a concise description of the epidemiology, diagnosis, and current treatments of MSA. And the paper by Tan and colleagues provides valuable insights and summarizes the current literature on the genetic risk factors for familial and sporadic multiple system atrophy, and also gives clues as to how these may be linked to the biological mechanisms that support the role of genetics in MSA. On clinical presentation, so when the person with MSA is being evaluated by a physician, MSA appears with a combination of autonomic failure with Parkinsonism or autonomic failure with cerebellar ataxia. And in some people, they have both a bit of Parkinsonism, a bit of cerebellar ataxia, in addition to the autonomic failure. So MSA is really classed into two types: MSA-P, which is MSA with predominant Parkinsonism, and MSA-C, which is MSA with predominant cerebellar ataxia. The features are progressive and may not all be apparent at the beginning, and the subtypes are therefore based on the predominant motor features accompanying the autonomic features at the time the person is evaluated or in the course of being seen by the physician. The accuracy of diagnosis is improved by applying the diagnostic criteria set forth most recently by the Movement Disorder Society. And the diagnosing physician utilizes a combination of the essential features, clearly defined core clinical features, supportive clinical features, as well as brain imaging MRI findings where available, and then also by carefully excluding conditions that may mimic MSA to further differentiate clinically established versus clinically probable MSA. Now, these new diagnostic criteria also highlight the possibility of what's known as prodromal MSA, possible prodromal MSA actually, that may enable earlier diagnosis of MSA before all the features that are characteristic become apparent. And the possible prodromal MSA category has been devised to capture MSA patients at the earliest prodromal stage when symptoms and signs are not fully apparent but are present, but are insufficient to make that diagnosis of clinically established disease. So this is really, the prodromal category is a research category with limited specificity, and it does need further validation. That's because the features that are captured therein may relate to other conditions and not necessarily MSA itself. Again, further details are beyond the intended scope of this talk, but colleagues interested in more details are invited to read these two articles that are publicly available. So as I have said earlier, the features of MSA really fall under these three main categories. And these are the predominant features, even though I must mention here that in addition to these features, people with MSA also describe other complaints related to mood, depression, anxiety, and problems with memory as well. But in the main, the characteristic features used for the diagnosis are the features of autonomic failure, the features of poorly responsive Parkinsonism. So a person with features of Parkinsonism who's not responding to the typical treatment with levodopa or is not responding consistently to it. And then the cerebellar syndrome of gait ataxia with dysarthria. So in coordination of speech as well, slurring of speech, in coordination of the upper and lower limbs, and then in coordination in oculomotor function. So there may be what is known as nystagmus, the eyes may dart to and fro. Now, autonomic failure is an essential component of the diagnosis of MSA. And as earlier stated, persons with MSA experience a wide range of autonomic dysfunction, including genitourinary dysfunction, so problems with bladder control, orthostatic hypotension, meaning that when they change position, for instance, from lying to standing or sitting to standing, the blood pressure drops without correction, and that can lead to dizziness. Respiratory or breathing difficulty, including stridor, problems with gastrointestinal control, and like I said, with sweating and regulation of body temperature. However, the most predominant autonomic features in MSA seem to be the genitourinary dysfunction and orthostatic hypotension. And in men, it's the usual first symptom of genitourinary dysfunction is erectile dysfunction, which is usually the earliest symptom of MSA. And others like urinary incontinence and incomplete bladder emptying can also occur. I want to highlight here that because of the wide variety of symptoms that MSA may have, MSA can present to a wide variety of physicians, allied health practitioners, and must be considered when a person has complaints relating to the myriad manifestations. So someone with MSA can present first to the neurologist or to the ENT if there's stridor or dysarthria or dysphagia, difficulty swallowing, or present to psychiatry on account of anxiety or depression, or present to sleep medicine on account of sleep apnea or excessive daytime sleepiness or restlessness in the legs, or present to cardiology on account of syncope or orthostatic hypotension or leg edema, for instance, or present to gastroenterology because of the difficulty in swallowing or constipation or diarrhea, or present to the dermatologist on account of loss of sweating or reduced sweating and the changes that occur in the hands because of autonomic involvement, and then may present to the urologist because of sexual dysfunction, urinary urgency or frequency, urge incontinence, urinary retention, and so forth. So it's important that every single healthcare practitioner is aware of the features of MSA in order to have a high index of suspicion and make earlier diagnosis. Now, like I mentioned, in addition to the classical features of autonomic failure, cerebellar involvement, Parkinsonian features, people with MSA may also have other symptoms that physicians don't commonly recognize. So this Global Multiple System Atrophy Register, the GLOMSA, was established in 2013 and is an online patient-reported contact registry, open and free to people with MSA, that relies on self-reported diagnosis by the patient or the caregiver, and really involved a global population, even though the numbers for Africa and Middle East were lower than the rest of the world, and a wide variety of symptoms, including things like change in handwriting that we don't often pay attention to, were described by people with MSA. So really a wide variety of symptoms relating to the multiple system involvement in MSA. Now, in the next few minutes, I'll describe what we know about MSA in Africa, I must confess that awareness about MSA across Africa is limited, and this includes amongst healthcare practitioners, the lay public, the media, and we must do a better job of getting the information out there in spite of the many competing health agendas on the continent. Everyone with MSA across the world deserves to have an early and correct diagnosis and be offered treatment with the treatment overseen by a multidisciplinary team with interest in multiple system atrophy. So what do we know? Now, the burden of MSA in Africa is not clearly known or documented. However, there's no reason to presume that the epidemiology of MSA, that is the prevalence and incidence overall, differs from the globally accepted ranges. So based on the fact that Africa's population is currently about 1.5 billion people, and given the global prevalence and the global incidence of new cases, it's estimated that there may be up to 72,000 people living with MSA in Africa, and between 9,000 and 10,000 new cases occurring every year. Now, this is higher than the numbers reported for North America, the US and Canada combined, and for Europe, given the higher population of Africa, and that's the denominator there. Although the differences in population structure may modify the ratios and estimates that are presented here. But this seems to be a fair estimate of the numbers. So to put it in context, it's estimated that about 15,000 to 50,000 persons were living with MSA in the United States of America in 2022, and about 1,800 in Canada in 2020. In addition, to this, I must also highlight that because of the structure of Africa in the past, where we had a predominantly younger population, we may have had fewer cases of MSA. But with the aging of the African population and longevity, it's likely that the burden of MSA in Africa will match that described in other global populations. Now, much of the published data regarding MSA in Africa is derived from hospital-based reports. So, for example, in this study from Madagascar, Nomena and her colleagues described MSA as being the most common atypical form of Parkinsonism reported. This is also similar to what we have found in our hospital in Lagos and in our movement disorder clinic, where MSA in this particular report was also the most common atypical form of Parkinsonism that we diagnosed at the time. This third study is the largest study reporting specifically on atypical Parkinsonism and MSA in Africa, and was published by Riyad Gouda and his team from Tunisia in 2021. It was based on hospital data collected retrospectively over a 17-year period. And the graph is adapted from their data, indicating the percentage of participants with each of the atypical Parkinsonisms. And we can see that MSA comprised about 15% of all atypical Parkinsonisms. Their study found no sex difference for MSA. And importantly, the mean age at onset of MSA was also similar to what has been described in other populations, so in the late 50s. And of note is that the mean diagnostic delay was about 3 years from the onset of symptoms, again highlighting unawareness and late presentation, but also delayed diagnosis even when complaints are made to physicians. So in this graph, I've summarized the publications that are available regarding MSA in Africa. Now, all these studies have been hospital-based. If the study was not reported in PubMed, I may have missed it out, but it's not likely that much has been missed out. And so it shows that we have reports regarding MSA from 5 countries published, starting in 1998 from Senegal by Ka and colleagues, and down to the most recent in 2021 by Nomena and colleagues, and in total represents reports on 140 people with MSA across Africa. And in general, the reports have been similar with respect to the profile of MSA as described in other populations. Now I'll switch and talk about support and community engagement regarding MSA in Africa. It's really commendable that these three highlighted initiatives provide support in some form and engage their communities to create awareness about MSA in Africa, including sharing their lived experiences, providing training to healthcare professionals, and supporting cash and kind to people with MSA to support their access to medicines and so forth. I'd like to really acknowledge the Fumilayo Fashion Foundation in Nigeria. The FF Foundation is a partner in this conference, I understand, and was established to honor the memory of a Nigerian woman by the name of Fumilayo Fashion who died of MSA, and her family really galvanized support and have continued to provide education and awareness and so forth for people with MSA and other Parkinsonism in Nigeria, and really are the leaders of this efforts to create awareness regarding MSA in Nigeria and across the West African sub-region. Also, I want to also mention and acknowledge the MSA in South Africa with Sonia blog. And this blog was created to reflect on the journey of an MSA patient from South Africa, Sonia Van Ryn, who passed on in 2017. The blog was initiated and created by her friend, Karen. And really, the blog is an excellent resource to learn about the journey of a person with Parkinson's disease, with MSA, I'm sorry. Now, the other blog is that created by Neil Dean, who started the blog to share his journey with MSA and also create awareness of the condition. And these are excellent resources for learning about the personal and lived experience of people with MSA in Africa. Now, as I begin to round up, I now want to describe the gaps and unmet needs. Clearly, awareness, as it is in many parts of the world, is really minimal regarding MSA in Africa. And then the social support for people with multiple system atrophy is also quite limited. We also have challenges regarding diagnosis and management and research gaps. Now, this is by no means an exhaustive list, and other perspectives can certainly be incorporated even within these broad areas. By the very nature of these gaps, they will require multiple strategies. They require many stakeholders in the private and public sector and many partners to work in areas in which they can exert an influence and impact the field to change the narrative. And individuals themselves have a role to play in also creating awareness in our spheres of influence to spread the word and lend support. Regarding diagnosis and management, we are challenged by the really limited diagnostic knowledge of physicians and allied health practitioners regarding the diagnosis and treatment of MSA, and then the health workforce capacity for multidisciplinary management of MSA, including physical therapy, speech therapy, occupational therapy. We have very few numbers of this type of multidisciplinary health workforce across Africa. And the access to therapies for management across the lifespan of MSA are also grossly limited in Africa. So not just pharmacological therapies that may be useful for the symptoms, but also the non-pharmacological devices that can be employed in treating the problems with gait and balance. We also have research gaps in knowing the true burden of MSA in Africa. We don't have any community-based studies that address this specifically. The profile of MSA in Africa is not well understood. As I had presented, we have barely 140 cases described cumulatively in the literature regarding MSA in Africa. And there are certainly diagnostic and treatment gaps that we need to research and understand better, and also understand by way of research the lived experiences of people living with MSA in Africa and their outcomes. We do have opportunities really to change the narrative. And the three areas I'd like to highlight in this talk are global collaboration to promote MSA awareness, the opportunity for capacity building for healthcare delivery and research, and then the role of big organizations like the World Health Organization in providing a roadmap and direction for governments and non-governmental organizations to implement policies that will improve the outlook of MSA in Africa. So first, regarding the global collaboration, clearly this conference is one of such. So we now live in a virtual one world, and we can harness the benefits of social media, and the level of penetration of social media is really impressive, even in underserved areas. And a conference such as this is really one that can promote awareness about MSA. The capacity building for healthcare delivery and research is ongoing, and I'd like to commend the International Parkinson and Movement Disorder Society, and particularly also the MDS Africa section, for the work that it's doing in educating physicians and allied health workers about atypical Parkinsonisms, including multiple system atrophy, across all of Africa. I'd also like to commend the Global Parkinson Genetics Program that is not only conducting research, but is building capacity of researchers in underserved areas across the globe to conduct research in a wide variety of Parkinsonian disorders, and most recently have expanded the scope of the GP2 program to include atypical Parkinsonisms. I also want to mention the Transforming Parkinson's Care in Africa project that's sponsored by the United Kingdom National Institute for Health and Care Research, that's funding a multi-scoped study that includes exploring not just the burden, but also the lived experiences of people with Parkinsonism and capacity building across Africa. And also commend the FF Foundation in Nigeria that I mentioned earlier, along with the bloggers who are creating awareness about MSA, and also other neurology associations, residency training programs across Africa have an opportunity to also spread the word in whatever way they can, incorporate it in the curriculum. The African Academy of Neurology does a great job of educating neurologists and the public across Africa, and are able to highlight MSA in the context of atypical Parkinsonisms. And the World Federation of Neurology and the European Academy of Neurology are also doing a lot of work on the African continent, educating neurology residents and other physicians about neurological disorders that include MSA. And then the World Health Organization has an intersectoral global action plan on epilepsy and other neurological disorders that really uses epilepsy and Parkinson's disease as tracer conditions to highlight and also promote better care for people with neurological disorders. And it's excellent that the issues regarding MSA can be piggybacked upon these initiatives. And the WHO Parkinson's Disease Technical Brief also covers, provides an opportunity really to incorporate atypical Parkinsonisms and the resources that are being built for the care of people with Parkinson's disease in the broader context to relate to MSA. So I want to summarize and say that this virtual conference is a great opportunity for us to globally join together in this our virtual one world and create awareness about MSA, and also join forces to ensure that we improve the quality of care and outcomes of people with MSA across the world, including in Africa. Thank you for your kind attention.